Hello, welcome to the Cytokine Signaling Forum Authoring Podcast. I'm Professor Peter Nash from the University of Queensland, and today about a paper recently published analysing the influence of age and renal impairment on the pharmacokinetics of Filgotinib, a JAK1 selective being studied for the treatment of rheumatoid arthritis and Crohn's disease. So welcome, Florence, and thank you for your time today. Can you tell us a little bit about your background? Are you a pharmacologist?
By background, I am a pharmacokineticist. I am working in the pharma industry for almost 30 years, and I have been working in big pharma at Aventis, and now I'm working for approximately 10 years at Galapagos, and I am heading the clinical pharmacology group at Galapagos.
A bit about the molecule Filgo. We're very interested in JAK1 selective, whether it really will make a big difference to benefit-risk ratio compared to the pan-JAK used to. Can you tell us a little bit about the molecule?
Filgotinib is indeed a JAK1 selective inhibitor. It has a selectivity towards JAK2 about 30-fold. It is compared to other JAKs more selective than, for example, tofacitinib, which is the one which is and baricitinib, which is the two ones already registered.
But the difference is really that you have an active metabolite. Can you tell us a little bit about the potency between the real metabolite?
Yeah, we do have indeed an active metabolite. This metabolite is also JAK1 inhibitor, and it has the same relative potency toward JAK2. But compared to Filgotinib, it's about less potent than Filgotinib.
Right. So does that mean we should pay attention to the levels of the metabolite?
Indeed, both should be taken into account, yes.
Okay. And you selected to study age and renal impairment. Why did you select those two? Does food not count? Does BMI not count? Does race not count?
So the importance to get the data in these two populations is linked to the disease area and also to the pharmacokinetics of Filgotinib. So for the disease area is a chronic disease that may require lifelong treatment therapy and the extension of treatment in older patient population. And with age, the organ which is the most affected is the kidney, with a decline of the glomerular filtration with age. And with regard to Filgotinib, its elimination occurs via metabolism followed by renal excretion. So that's the two reasons why it was of interest to investigate the effect of age and renal impairment on the PK of Filgotinib when treated ARA. With regard to food, we have tested food effects in several studies, and we have not seen any food effect. And with regard for other covariates, as you mentioned, race, gender, these are typically analyses or effect we will analyze with a large trial in phase 3. We have not dedicated phase 1 studies to assess this type of effect of covariate on the PK of Filgotinib.
Okay, and do any drugs interact with the level of the metabolite?
No, not at all. Filgotinib is a very easy compound to co-administer with other drugs. It has a very low DDI liability. I have published another paper on the low DDI liability of Filgotinib with other drugs. It's a drug which is metabolized by carboxylesterases, and it has no potency to inhibit or induce CYPs.
Okay. I was interested to see the CES2 inhibitor is unusual for JAKs.
To be honest, I think it's the only one JAK I know that is metabolized by carboxylesterases. For the others, tofacitinib, baricitinib, and as well badicitinib, they are not using the same metabolic pathway.
Okay, so tell us a little bit about your study, how you did it, and then later on what you found.
So first, let's start with the elderly study. So this is a study which has been performed comparing 3 groups of subjects. We have 10 subjects in 3 age groups, what we call the young age group, and 2 elderly group of subjects, with one of 65, 70 years old and the other one more than 75 years old. The PK of these two groups, elderly groups, were compared to the control groups, and we observed a modest increase in the exposure of both parent and metabolite by approximately 1.4-fold in the oldest age group, more than 75 years. So it's really a modest increase and change in the PK of the filgotinib. With regard to the other study, which was the idea was to analyze the effect of the renal function, of the impairment of the renal function on the PK of the filgotinib. Here, the study was performed in two parts. First, we used, as described in guidelines, the reduced PK design, which means that we compare the extreme of the renal function patients, severe renal impairment to healthy subjects, and we look at the change in the exposure. And based on this data, we decide to include more people with varying degrees of renal impairment, mild and moderate, to assess the full effect of the renal impairment on the PK of filgotinib and the metabolite. For this study, the result shows that in severe renal impaired subjects, we have an increase of the metabolite exposure of 2.7-fold and of filgotinib exposure of 1.5-fold. So it looks at age as a minimal impact on the PK of filgotinib, and we have an effect on metabolite exposure in the severe renal impairment. But this has to be also taken into account with a small number of subjects used in the severe renal impairment group. We have only 3, and it was mainly due to the fact that we review the study design.
I was going to ask you 3 patients
on these 2 studies, you mean, Peter?
Yeah, because, really 2.7 times fold significance, and do you think that means we have to cut the dose from 200 that they're going to market down to 100?
No, I think it's a bit premature to say what will be the impact.
A little bit like I said in the formula. Okay. You're studying 100 milligrams, 200 milligrams. Is it going to be a bigger difference?
The reason why we study 100 milligrams in these 2 phase 1 studies was because we know that a change may be expected on the pharmacokinetics because, as I said, the compound is eliminated by the kidney, and in elderly and renal impaired subjects, we have a change in the kidney and the glomerular filtration rate. So we were expecting some change, but we don't know exactly what was the magnitude of the change. So that's why for these 2 phase 1, we use a 100 milligram QD dose to ensure that we have room in case of potential marked increase in exposure. But I would just like to say that in phase 3 studies, we are investigating 2 doses, not only 200. We are investigating 100 and 200 milligram QD to provide an assessment of filgotinib dose response relationship for safety as well for its efficacy. So we have 2 doses in phase 3, and one of these doses has been used in these phase 1 studies just to ensure that we have enough room. Yes, Peter?
It'll be like baricitinib, where you recommend the 2 milligram dose.
No, I think at this stage it's a bit premature to say what will be the impact of the change, in particular in severe renal impairment subject, because first the number of subjects is small, and you know that it has been to look at all the safety and efficacy data we will have once the phase 3 FINCH study will be completed. But to date, we do not anticipate those adjustments for filgotinib. But as I said, we need to review all the efficacy safety data first to make a judgment on those recommendations.
What recommendations to make to the clinician based on these 2 studies?
As I said, today it's a bit difficult to make recommendation. I think that the data show and confirms a good safety profile and easy use of filgotinib in clinical practice, and that the change we observe will be judged in light of the phase 3 efficacy and safety results. It's a bit premature to make a judgment yet today.
Okay, so we need more data, that's fine. Any comments on what these studies tell us how long we would expect the medical effect to wear off if we stop the drug?
You mean how long we will have to wait if we need to stop the drug? That's what you mean?
Yes. Yes, because patients will ask us of different ages, different renal function. They'll say, I want to fall pregnant. I want to stop. How long before the drug and metabolite is gone?
For the drug, Filgotinib itself, the half-life is around 12 hours, 6-12 hours. It's a bit variable, but it's the decrease in plasma concentration will be observed quite, let's say, in three days. While for the metabolite, which has a longer half-life, about 1 day, it will take 5 days. So a bit, let's say in 1 week, the drug will be off, drug and the metabolite will.
So that's very helpful for the clinician who has to plan surgery and other things.
Yeah.
Any other comments you'd like to make?
I think that these two studies are very small studies, but informative studies that support the development of Filgotinib, and in particular, this information were used to guide the inclusion and exclusion criteria for phase 3 trials. So it's a small study which are informative to develop drugs in general.
Okay, and is very different to the other JAKs?
It's a bit difficult to compare with other JAKs because they have different metabolic pathway, as we just discussed before, than Filgotinib. So also JAKs have dose adjustment for age and renal impairment, as tofa and tofacitinib. That's correct. But as I said, for Filgotinib, taking into account the change we observed, we are not dose adjustment is not anticipated. But the final say will be when we have all the phase 3 finished data available.
Okay. Now, an impossible question for you to answer. Do you believe that JAK selectivity has suffered clinically or from a side effect point of view? Because it's been very difficult to show that so far.
As you said, it's a bit difficult for me to answer, but when you look at the results in Darwin and studies, I think that the safety of Filgotinib was quite good compared to other JAKs. So would it be due to the selectivity or other factors or characteristic of Filgotinib? A bit difficult to answer, but at least at the clinical trial phase 2b, and I hope phase 3 trial will show that indeed Filgotinib has a better safety profile than the other JAKs.
Right. Well, the poor clinician has 4 JAKs to try and work out which to use. Do you think you would ever do a head-to-head between them?
That's indeed a difficult question because you know that we are developing Filgotinib in collaboration with Gilead, so it's a discussion that we'll have to be within the two companies. Today it's not planned, but I think the safety will be likely one of the criteria to select one of the 4 JAKs. And if you ask me, of course, I will tell you that Filgotinib will be the best one.
Good. So what do you think is the take-home message from this study, both for effective age and renal?
Yeah, I think the take-home message of these 2 studies is that the effect of age and mild and moderate impairment is modest. For severe, let's see what the phase 3 data will tell us and how we have to handle. Based on this data, dose adjustment is not anticipated. And yes, the take-home message is also the good and safety profile and easy use of Filgotinib. I think overall it's a compound which has quite, for clinician, is an easy use because it has no drug-drug interaction liability, marginal effect of age and renal impairment. So I think it's an easy drug for clinicians.
Your time, Florence. If you'd like to know more about this paper and others uploaded, you can get detailed slide sets are available in the publication section, cytokinesignaling.com. Please subscribe to this podcast on iTunes and let us know what you think.
Okay.
Thank you very much for your time.
Thank you very much
for
the forum to invite me for this online discussion. Thanks so much, Peter. Bye-bye.